This session is on head and neck cancer, and it gives me great pleasure to introduce our chairpersons, Dr. Devendra Jain, Senior Surgical Oncologist from Udaipur, Dr. Narendra Rathore, Senior Radiation Oncologist from Udaipur. I request our chairpersons to please come on the first row.
Good evening, everyone. I would like to invite Dr. Amol Patel, medical oncologist, for his experience and talk regarding real-world experience of immunotherapy from India in recurrent squamous cell carcinoma of head and neck cancer.
So you can start.
Hello, ladies and gentlemen. Firstly, thank you, Dr. Manoj, for bringing me here for this wonderful concept of the meeting, which is focusing on real-world series and the experience or the publications from the India which are going to be discussed. Which, in sense, this is what we require. For advancing our own research and solving our own problems. Thank you once again, Dr. Manoj. So, a topic given to me is the real-world experience of low-dose immunotherapy. I don't know how the organizers come to know about this real world and where they got this the idea that I am using the low-dose immunotherapy Yes, I am using low-dose immunotherapy for a couple of years now. So the first case report came from none the other than what we call is the alma mater of oncology, that is the Tata Memorial Hospital, Mumbai. Herein, again, the team of medical oncology, the Kumar Prabhasar and Patil and the Abrahamji, they reported a case wherein they used the low-dose immunotherapy at a dose of 20 milligram of nivolumab with the consent of the patient, and they showed that it is a viable option. And such kind of early experience in head and neck cancer came from India. When we see the concept of using the lower doses of immunotherapy molecules in various malignancies, the Koreans were the first one to report their experience in lung cancer. And what they said, what their experience in their country, that those patients who are coming with the less insurance and they cannot afford the kind of 100 milligram or 240 milligram, whatever the out of pocket, they group them in 20 milligram nivolumab and 100 milligram. And what they showed that low dose nivolumab can be effective in non-small cell lung cancer, and it is worth considering an alternative option. It was published in ESMO Open. Though we require a lot of trials where in phase 2 or phase 3, but such kind of a real world data are eye-opener. To mention that the concept in the Canada, what they use as as a policy in their country is based on the cadet document. It is basically a technology review, and everything for any technology, any new molecule, they use on the basis of certain fundamental research. So this technological research, the report was really eye-opener for me when I have gone through this dosing and timing of the immuno-oncology drug, how they have got into the milligram per kg dosing for nivolumab, pembrolizumab and durvalumab in Canada. It is really admiring. This was statistical modeling wherein they showed that the immunotherapy drugs need not to be used the way the conventionally they are prescribed for cost saving and rationalizing the resources. So when the publicly funded countries are working like this, why we should not be doing such kind of use of such costly drugs wherein the majority of the patients can be benefited. So this is my single center experience. I joined here in Mumbai in August, and for over 2 years, I have been using the low dose immunotherapy, particularly in head and neck cancer, Hodgkin's lymphoma, and renal cell carcinoma. Obviously, I have some trial running on for the lung cancer and the gallbladder cancer. So today I'm going to discuss about the head and neck subset. As a protocol, we are using low dose immunotherapy at our center since August 2020. For all these patients, we do inform them that what we are using and what is kind of a benefit they are going to get in the lack, whereas there is a lack of such kind of the trial which is phase 3, the way the research is published. Our guidelines do come, and surprising to us, every patient do agree with the consent, and that is what we have suggested. Myself and Professor Ian Tannock and Goldstein from Israel, we in our publication in Annals of Oncology, if it is to be conveyed to the patient, and if patient is giving the written consent for using such therapy, possibly this is the only way forward. And that article has been really appreciated throughout the world. With this, out of the 47 patients so far, each and every patient which I have treated with the immunotherapy drugs at my hospital, the 7 patients were from head and neck cancer. Obviously, the buccal mucosa remains the commonest site, along with the one patient had tongue involvement and the lower alveolus. It's a massive growth, which were and the other sites were the maxilla supraglottis and lower alveolus. The median age in this experience was 57 years, and it is predominated by the male, and it is as the national whatever the parameters we have as a national figures, these are similar to that. Mean weight, and particularly coming to this point, because even if you take the weight-based dosing, the dose do not go for 240 milligrams. We make it 3 milligram per kg. In our series also, the weight is 50 kg, and with that also, the modified doses can be used for other centers. You can save a lot of nivolumab, which can be used for multiple indications. So in this real-world experience, the various lines of therapy, predominantly second-line therapy, 4 patients received, other received first line, and 2 patients. The nivolumab was used in 6 patients and pembrolizumab 1 patient. And patterns of use was not uniform, as clear to us. It is a real-world experience. So this is the kind of experience of all these 7 patients. In that, various clinical conditions are there. Out of this, 1 patient did very well, who is a case of CM maxilla, and he received initially paclitaxel and carboplatin weekly at Gurugram, and then he came to our hospital. He was brought by his son for further treatment. While going through this, we thought that adding this patient nivolumab would be a good idea, and when we add and completed the remaining cycles of paclicarbo, he really did well for 6 months. Then the other patients, the third line, where though there was a remarkable response for the first patient, wherein nivolumab was used as third line. He has received metronomic therapy, then paclicarbo-cetuximab. Though the local growth reduced in size, but somehow we didn't get the clinical benefit. There is a worsening his general condition. However, the PET scan did not show the progression. But somehow, patient in poor performance status, there are multiple issues, and over a period of time, I am going into the concept that in poor performance status, the immunotherapy use should be restricted. Anyway, when it comes to the practice, and there is a lot of ongoing the stress from the on family, and they want to do see the age of this patient is just the age is 50 years, and everybody wants some kind of a treatment for their family members. 3 patients, they are ongoing. They have almost completed 2 months of oral metronomic plus in low dose nivolumab. After the Vijay Patel study, initially I used to use 40 milligram 2 weekly, but after the TMH study, we have reduced dose further to 20 milligram. Though in one of our patients, we did use 20 milligram around 2 years back. Experience with the pembrolizumab, as expected, the patient did not have the PD-L1 expression. It was 0%, and though within 2 cycles, the patient progressed, and after that, patient was shifted to the cisplatin 5, carboplatin 5 plus cetuximab, and now he's doing well. So, saying that, the real experience, real world is very much challenging. It is not that easy the way we see, because there is a lot of patients, multiple, they have ongoing therapies, and now the nivolumab with a low dose has come up, and there are multiple avenues are opening up how to use these drugs along with the oral triple metronomic therapy. The PD-L1 expression range is varied. The method used is varied. Somebody may ask in the present while seeing the presentation that why you have done SP142, why there is no uniformity. But we don't have in-house facilities, and in the beginning we had some offers from some of the companies, and they could do the PD-L1 expression for us. This is just a part of cost saving, and you may argue for that. Anyway, this is our experience. And when it comes to, again, real world environment, there are always challenges. One patient particular to this group, I want to highlight here, because there are a lot of issues involved in the management of this case. Like, it is a 51-year-old male, CA buccal mucosa, squamous cell. It has involved the floor of mouth, tongue was involved. However, the anatomy permitted for the surgery, but somehow he suffered from COVID-19. It was moderate, and the surgery was deferred for 1 month. As a policy, because of the increased thromboembolism episodes, the minimum time, whatever our team has decided, is for 1 month. The referral was given to me for NACT, because and they said that 1 month, how we were going to do, because there is always a dilemma and challenges in such situation. But the patient had rapid clinical worsening, and the pain and the size of the lesion reached midline, and the surgeon was very much worried that if something is is not done, then he might lose on the surgical aspect. Patient was unfit for the surgery, and then because of the basically the issues with the COVID-19 and the DCF, when I was contemplating the risk, again the same thing, and how long, if you just don't have to stop 1 month, 2 months, then you really have to go ahead with all the 3 cycles. I explained the nature of oral triple metronomic therapy with a low dose IO to patient. He agreed. And I think there are already the trials going on comparing head to head with such kind of a regimen, because such kind of response rate of therapy with the oral triple metronomic therapy with the low dose IO, the 65%, it is unheard of in head and neck cancer. We always believed that it is kind of a stone, it is a stony disease, nothing works here, and we have seen that. Sometimes the patient might be pain relieved, but we don't see the responses. But here, magically this drug combination is working. I just shared these images to Vijay Patil also, and I told him that the innovations, the way the TMH people have done, and this is how there is so much of anatomical. You can see here. There is the growth was completely occupying the tongue and the oral cavity. Here it is almost all the air passes they got freed. If we see this imaging, and in head and neck cancer, it is always we see how patient perceives, what is his take on it, which is equally important. So let's see what our patient is going to say this.
आप हमारे साथ अपना विचार शेयर करें कि आपका एक्सपीरियंस कैसे रहा है, आपकी गांठ के ऊपर कितना असर पड़ा है कीमोथेरेपी के बाद, और आप कैसे फील कर रहे हैं?
हम अच्छा फील कर रहे हैं सर, और जहाँ तक गांठ की सवाल है, वो कीमोथेरेपी का हमारे ऊपर कोई साइड इफेक्ट भी नहीं हुआ, और बहुत अच्छे तरीके से गांठ धीरे धीरे करके निकल गया।
अभी आप कैसा महसूस कर रहे हैं?
बहुत अच्छा महसूस कर रहे हैं।
ठीक है, धन्यवाद योगेश्वर सिंह।
धन्यवाद।
So, why saying this for you, everybody is whether it is oral chemotherapy or immunotherapy, the chemotherapy is such a rampantly word used. The patient said chemotherapy, however, he received the oral triple metronomic therapy, and that too gefitinib along with etrocobzib and methotrexate, 15 milligram per week, and nivolumab 20 milligram with the every 3 weeks regimen. In that post 6 weeks, these are the changes I have shown. There is a blockbuster, I would say, for India from Vijay, and we all hearing this success story. We have never seen such kind of the separation of the curves in head and neck cancer, and see the 1-year OS improvement rate. When it comes to the ground, we always see whether this evidence is adequate. These are the case series, report, personal experiences. Do we still need phase 3 data? There are criticism will arise that we want standard dose versus low dose, but somehow if such kind of wonderful results are there, I think there are no barriers for using such kind of therapy in the clinic, considering when the cost remains the biggest barrier for access to care. So real world is like this, and we saw the inauguration, and when the things do come to our notice, the buffaloes created ruckus, and the one day our train, whatever recently launched from Ahmedabad to Mumbai, they had a massive accident because of these buffaloes. But yes, again the train reached to the Mumbai or CST, wherein the repair was done immediately. So this is the new world, this is new India, and I thank you for your patient listening. If there are any questions, I'm okay to take it. Thank you.
Thank you, Dr. Amol, for this nice presentation, and it's been an eye-opener for we surgical oncologists also. Now I would like to invite Dr. Hemant Dadhich. He'll be presenting the data on the phase 3 randomized study evaluating the addition of low-dose nivolumab to palliative chemotherapy in head and neck cancers.
Good evening, everybody. I will thank to Dr. Manoj Mahajan for inviting me for here for this conference. I will present phase 3 randomized study evaluating the role of low-dose nivolumab to palliative chemotherapy in head and neck cancer. This study originally presented by Dr. Vijay in ASCO by head and neck group of TMH. As we know, the head and neck cancers are accounted for approximately 9 lakhs new cases, and out of that 4.5 lakhs deaths worldwide annually. Despite advances, approximately 50% of the patients with locally advanced head and neck cancer develop recurrent and metastatic disease with due course, and they have a very poor prognosis with median OS of less than 1 year. The extreme trial has established survival benefit in arm of cetuximab plus chemotherapy in comparison of chemotherapy, and this extreme study has established cetuximab plus platinum-based chemotherapy for 6 cycles, followed by weekly cetuximab maintenance as a standard of care in patient with recurrent and metastatic head and neck cancer. And the extreme regime was the first regime in 30 years to show significant improved in overall survival versus chemotherapy. Checkpoint inhibitors in head and neck cancers, 2 anti-PD-1 agents has been approved in recurrent metastatic head and neck cancer, nivolumab and pembrolizumab. The randomized phase 3 checkmate study, we compared nivolumab versus investigator choice of chemotherapy in patient with recurrent metastatic head and neck cancer who is progressed or recur within 6 months of last dose of platinum-based chemotherapy. And this study has shown that the survival benefit in nivolumab arm versus investigators of chemotherapy. The phase 3 keynote 048 regime for randomized trial has shown that the has recruited patient of squamous cell carcinoma for head and neck cancer who has recurrent or metastatic disease and which is incurable by local therapy, and patient who had ECOG performance status 0 or 1. In this study, patients were randomized between 3 arms, pembrolizumab monotherapy or pembrolizumab plus chemotherapy and extreme regime. If we see the result of this trial, even CPS more than 1 population or CPS more than 20 population, the overall survival was much better in single agent pembrolizumab arm. And if in chemotherapy plus pembrolizumab arm, in total population, the overall survival was much better in pembrolizumab plus chemotherapy arm. So, both nivolumab plus pembrolizumab are FDA approved in platinum refractory patients. The pembrolizumab in first line treatment in recurrent and metastatic head and neck cancer as a monotherapy in patient who had CPS more than 1, and in combination of platinum therapy plus 5-FU as a front line for all patients. And there are multiple treatment strategies combined with immune checkpoint inhibitors in currently under investigation. This trial was done by TMH and published in Lancet Journal. The low-cost metronomic chemotherapy versus intravenous cisplatin in patient with recurrent and metastatic inoperable head and neck cancer. And this trial has shown that the oral metronomic chemotherapy is non-inferior to intravenous cisplatin with respect to overall survival in head and neck cancer patient in palliative setting. And it is associated with fewer adverse events, and it is therefore represent a new alternative standard of care if current NCCN approved option for palliative therapy are not feasible. If we see the metronomic versus other palliative systemic therapy, the overall survival or median survival is comparable. Even in oral cavity cancers, the median survival was 7.8 months in compared to 4.5 months in cisplatin plus 5-FU, and toxicity as well as cost is much less in oral metronomic therapy, and it is very easily accessible for us. Compared to cetuximab in India, only 3% patient can afford. With this background, as we know, the access to cetuximab or checkpoint inhibitor is less than 5% in low middle income group countries. The oral metronomic therapy has proven overall survival of IV cisplatin. It is a low cost and affordable with minimal side effect, and it improves the quality of life of patients. the triple metronomic chemotherapy is next generation metronomic regime, and it has a response rate of around 43% in platinum refractory settings. As we know, less than 50% with immunotherapy. However, response are short-lived in contrast with immunotherapy, in which response are usually has a longer duration. For nivolumab is anti-PD-L1 monoclonal antibody. For its works, it requires at least 70 to 75% need to occupy on T cells, and this occupancy can be achieved at a dose of 0.3 mg per kg dose. There are multiple retrospective analyses shown that this low dose may be effective. Hence, this study was planned to assess whether addition of low dose nivolumab to triple metronomic therapy might improve survival. The trial schema was adult head and neck cancer patients who planned for palliative therapy were and had ECOG performance status 0 or 1 were randomized 1:1 fashion into palliative chemotherapy versus palliative chemotherapy plus nivolumab, and primary endpoints was overall survival. Secondary endpoints were PFS, quality of life, and adverse event. In this trial, the triple metronomic regime included tablet methotrexate 9 mg per meter square weekly, erlotinib 150 mg, and celecoxib 200 mg twice a day. Nivolumab was given 20 mg intravenously every 3 weeks, and response assessed every 2 months with axial imaging. Adverse event assessed on every visit and recorded according to common toxicity criteria of adverse event version 4. 208 patients were assessed for eligibility, and out of that 151 patients were randomized, and 75 patients were randomized into triple metronomic arm, and 76 patients were randomized into the metronomic plus nivolumab arm. At the first interim analysis, 8 patients is still on continuing allocated treatment in triple metronomic arm. 67% patients discontinued because of progression, loss to follow-up, or adverse event. 2 patients died in this arm, and 2 patients were planned for surgery in view of good and sustained response. In metronomic nivolumab containing arm, 21 patients were still continuing allocated treatment. 55 patients discontinued either because of progression, loss to follow-up, or adverse event. 2 patients died in this arm, and 2 patients were planned for surgery in view of good and sustained response. The baseline characteristics were very well matched. Approximately 75% patients in this trial had tumor PD-L1 positivity. Nearly 60 to 70% patients had received prior treatment, and approximately 60% patients in this trial had platinum refractivity. Response usually seen within 2 months, as seen in this picture. The response rate were very impressive in both arms. By adding low dose of nivolumab has increased response rate around 15%. If we see the waterfall chart, the depth of the response were much deeper in nivolumab containing metronomic arm. The progression-free survival was 4.7 months in triple metronomic arm versus 6.7 months in nivolumab containing arm with hazard ratio of 0.56. By adding low dose nivolumab has increased 1 year progression-free survival from 3% to 27%. The median overall survival was 6.7 months in triple metronomic arm, comparing 10.1 months in nivolumab containing arm with hazard ratio of 0.54. By adding low dose nivolumab has improved 1 year overall survival from 16.3 months to 43.4 months percent. The adverse there was no statistical significant increase in adverse events, and adverse event of interest were also low occurrence in nivolumab containing arm, like hypothyroidism, rashes. The commonest side effects were anemia, hyponatremia, diarrhea, rashes, and mucositis. The median time to deterioration in quality of life was improved in most of domains. The physical functioning and role functioning quality of life domain were significantly improved. And the annual cost of current regime is approximately 5% of cost of Keynote 048 regime. In India, this regime will cost around 3 lakhs. So in conclusion, in this first ever randomized study in head and neck cancer patients requiring palliative systemic therapy, the addition of low dose nivolumab to metronomic therapy led to improved overall survival. And in alternative an alternative standard of care, those who cannot access full dose of checkpoint inhibitors. If we see, there is a no head to or randomized comparison between standard dose versus low dose of immunotherapy. But if we see this trial, the with other trials, the response rate, PFS and OS is comparable, but cost and toxicity is much less. So my take is, for country where majority of patient can't even afford protocol more than 30 to 40,000, this protocol should be standard of care. This study is better than the chemotherapy alone, but weight-based IO with chemotherapy or single agent IO for the selected group or TPX or extreme protocol still remain as a standard of care for the patient with advanced recurrent head and neck cancer not amenable to local curative intent of therapy. Thank you.
Any questions? Okay. Thank you, Dr. Hemant, for the wonderful insight about the immunotherapy in head and neck cancer. Now, I would like to request Dr. Vijay Patil, sir, for a panel discussion who will be moderating this session. NACT in head and neck cancer, when, where, and how. Our panelists are Dr. Ashish Kaushal from Ahmedabad, Dr. Ashish Kaushal from Ahmedabad, Dr. Ankit Agarwal from Udaipur, Dr. Saurav Sharma, Dr. Mukesh Chaudhary, Dr. Kanishk Mehta. Dr. Kanishk Mehta, please. And Dr. Shiv Kaushik.
I'll need some medals, so let me invite Moderator sir. And Hemant both, so both of you can come. Okay, done. So this, I actually always hate to do this late evening panels. By the time the whole crowd is tired and they are waiting of how fast we can finish. So what I decided is to keep it very practical, and most of the areas which we are going to go doesn't have much of level 1 evidence. So let's discuss what we do it in practice, and let's try to dissect out why we do the way we do. And so let me start with the surgeons. Let's say that a 49-year-old male walks to your OPD and it's a CA buccal mucosa. It's a T4A, N0, M0, and the T4A is because just the skin has got involved, but it is not extensive skin involvement. And the patient is fit with all respect, mouth opening is good. So what are your choices? Do you offer CTIT as a choice, or surgery is the choice in this situation?
Surgery.
Any difference of opinion here that anyone wants to do CTIT in this patient? Okay, and then that is absolutely fantastic and clear. And that data comes clearly. We always knew that oral cancers do well with surgery. The data comes very clearly from this randomized study done by Dr. Iyer et al., which shows that if you give CTIT, the 5-year DFS is 5%. If you do surgery, the 5-year DFS is 65%. So there is a huge benefit of doing surgery. And this is in spite of that patients being stage 4A and stage 3. So we had very few patients of stage 4B. So it's very clear in oral cancer, surgery is something which is very important, and it gives long-lasting results. With that, and we have 4 surgical faculties here, and I'll ask each one of them. Do you believe that every oral cancer can be operated, or do you think that in some oral cancers you might require help from medical oncologist or from radiation oncologist.
All oral cancer are not resectable.
Okay.
If it is early, then resectable.
Okay.
If it is advanced,
Okay.
then NACT is.
Okay. Saurabh?
High ITF involvement or perivascular encasement or something like that, they are not upfront resectable.
Okay, so you would have certain criteria. If they are present, you would send them for some therapy before considering for surgery. Dr. Mehta?
Also, I would think if the patient is presenting with metastatic lesion,
Okay.
that is one thing, or T4B,
Okay.
lesions forming skull base, cross involvement of skull base or even pterygoid, then probably I don't think I would be taking this patient.
Okay. Dr. Kaushik?
Yes, sir.
Same. Hemant sir, is that the practice in Jaipur also, that patients which are large and if they have disease going up to into the high ITF or disease very close to skull base, they would be sent for neoadjuvant?
Yeah, I think it is the practice. Maybe the evidence is not there. If you have a T8 or a T9 or a T10 lesion, as we see quite
Yeah.
frequently, then and the surgeon says, I can't do anything, disease volume is just too much to be handled by radiation, then there is not too much option.
I would agree with that. And the reason why we heard difference is because there is limited evidence here, and resectivity is not a very white and black area. These are zones of grays, and these zones of grays in the same institute can differ between surgeon to surgeons, and they can differ even between institute to institute. That's get very well dictated in this survey which was done by. Oh yeah.
One point I would like to mention, I don't have any scientific paper backing this idea, but whatever I have seen in my career so far, actually basically giving chemotherapy to the patient is like a test for the disease. Those patients who responds well to chemotherapy, actually then after that chemotherapy, aggressive approach towards surgery and CTRT generally gives better results.
Yeah.
Compared to those patients who are not doing well on chemotherapy, generally it is better to send them for further palliative chemotherapy.
That is correct, and that actually is backed by data both from Lisa Licitra, the Zhong study, and even from our retrospective analysis, where if the patients achieve PAT-CR or near PAT-CR, they do much better than patients who don't achieve that. And this is what was seen when multiple surgeons were asked, what would be the limit of you won't be operating if there are involvement, and the red means that they are not willing to operate. So if it's a total glossectomy or supraglottic laryngectomy, 93% said they won't operate. If total glossectomy, 93% said they won't operate. Total glossectomy, total 84% said they won't operate. The point I'm making is many times functional and both this the kind of biology which you have takes this into question. Obviously margins become important, and this is something like a boosting slide I have shown. This is data from Tata Medical Center Kolkata, where you have 10% nearly involved margins, and we at India are much better surgeons than what is there into the best of the world. And this is Dr. Jatin Shah, who is considered to be a legend in oral surgeries and head and neck cancers. And if you look at his results in T4, if you look at that red box, 45% in their centers have margin positive rate. In India, we have much less margin. That for Tata Memorial Hospital starts at around 5%. I showed you the data from TMC Kolkata. That starts at 5%. And so, that actually everyone answered that they would give NACT, and as was correct pointed out, we would do response-based therapies. But I just wanted to ask, you do a heroic surgery. Let's say that the patient relative says that I don't want to undergo neoadjuvant chemotherapy, but the medical oncologist says no, I don't think he's that fit enough to get a DCF. And if you still do a surgery in such extensive tumors, what would be the average lifespan or average chances that the disease will recur in how many months? Any idea? Okay, this yes.
Dismal results.
Yeah, that's correct, and that's what it seems. This unfortunately, these data don't get published, and I like the FHNO conference is because this data keep coming up in posters there, and this is from Ahmedabad, and it's a pretty big series. The series has around, we could see there are around 106 patients, and they divided it according to the things which we told about, that gross edema up to zygoma, it's gone high ITF involvement, skin infiltration. And if you look at the last column there, most of the patients had recurred before 6 months, and that's where I think the point which was well borne, that when you have a large disease, neoadjuvant chemotherapy not only helps you with margin but also selects the patient who is likely to do well. What if, I would have loved if a radiation oncologist was there, but if there is one in crowd, what if we give, what if we give CTIT in this patient? A large T4B going to skull base, we give radical CTIT. What would be the results? Yeah, so that's absolutely correct. Most of the people will try palliative. In TMH, we tried to be heroic, and in 30 patients, we tried to give radical CTIT. In fact, we lost many of the patients within a few months of completion of RT. The median survival in this group was around 6 months. And that's the, so let's say that we all agreed we would give neoadjuvant chemotherapy in a technically unresectable large tumor. What are the results? And we have a medical oncologist. So what are the results you expect when you give in such large tumors neoadjuvant chemotherapy?
I hope this is, we are discussing for
T4B oral cancer, technically unresectable, you are given neoadjuvant chemotherapy, then the patient gets operated. What is the likelihood of 1 year survival or 2 year survival in this situation?
I think it depends on the patient's general condition. Yeah. So it depends on the patient's general condition and what regimen patient can tolerate.
Yeah.
So we have a data of TEX 323 and 324 study. Even in patient of unresectable disease, if the patient tolerated TPF regimen very well, the 3-year OS is around 80-85% if the patient is the right candidate for aggressive treatment. But the Indian data is actually not that good.
Yeah.
So that's a limitation of the patients.
Yeah, I agree with you. The TAX 324 data actually showed good result, but TAX 323 by Dr. Varmokan, which was an unresectable, actually had a median survival of 16 months only in that situation. There is pretty data which has come from India, has come from Tata also, has got replicated from Kidwai also, and now this list has actually increased. And actually, this has got into a textbook chapter by Dr. Varmokan. He has devoted a complete chapter on technically unresectable cancers, and he clearly says that this is commonly seen in India, and the data comes from India only. You could see that the 2 years survival in this situation, if they get operated, they stand somewhere between 20 to 40% in this, and is variable across. Has got come into resource constraint guidelines of ASCO also, that if you are technically unresectable, you could try the neoadjuvant chemotherapy in these patients. So my questions to the surgeons and the medical oncologists is, patient is operable, comes with a paramandibular disease. Let's say it is near to the GBS, but the bone is not involved. You did a scan, the bone is not involved. Would use neoadjuvant chemotherapy for organ preservation, for mandibular preservation? And all four of you can take the question.
Right now,
Okay.
there is a trial I think going on in Tata for that.
Okay. Abhishek? Medical oncologist, any difference of opinion?
I think if the patient is a candidate of segmental mandectomy, if there is a superficial area, there is still a role of NSCT in those scenarios. We practice that.
Okay, you do
so we
practice
can
that.
convert from segmental to the patch in some patients.
In your practice? No. Okay, yeah. So again, I agree with what my colleagues have said. We have done a phase 2 study, and we give neoadjuvant chemotherapy in these patients and try to say whether the mandible could be saved or not. And we actually have published a data which now goes up to 8 years. You could see that 47% of the mandibles could be preserved, and that actually didn't have any inferior outcomes on the patients. But we are at present running a large phase 3 study. It has got around 60 patients have got recruited, and only time would tell what would be the correct way of planning in these patients. So coming to the medical oncologist, which is the choice of neoadjuvant chemotherapy you practice, and why?
So I think the most aggressive and effective regimen is DCF or TPF. We do in most of the patient who is fit for who can tolerate this regimen. And some patient where the triple drug is not possible, I think dual drug would be a second preference if the patient is not a candidate for open surgery.
Okay.
I think I'll agree. If we go aggressively, obviously TPF is much better. And as you correctly
said. The TOTIO data, there is one data in which they have, it's a retrospective data although, they have shown that the platinum with taxane is almost equivalent to DCF, but I think the number was not a big enough number wherein we can exactly say these two agents are equal. But TPF is obviously is better when we have a good performance data station.
Hemant sir, in your practice, how many patients out of 100 get TPF?
I actually don't like the DCF regime. I think in Indian patients it's too toxic. Plus giving 5FU the way it should be given is again pretty cumbersome both for the institution as well as for the patient. So my choice is cisplatin for the fit patient plus paclitaxel.
Okay.
I think there is some data from TMH that the PFS is the same, but possibly the OS is not same. But I don't like the DCF at all.
So we actually did this randomized study to answer this question. Only 496 patients, 1:1 randomized. This manuscript has got submitted, so hopefully in a few months now it will be available in public domain. And you could see that there was a benefit in PFS and OS which was seen with the TPF, but that came at quite a bit of toxicities. And the benefit, the hazard ratio that you said around 0.8, 0.9. So there is a minimal incremental benefit of giving 3-drug regimen, but it comes at quite a bit of toxicity to the patients. In fact, grade 3 and more toxicities were seen in 78% of the patients in this study. And so that came with that toxicity. We normally have a way of giving TPF at Tata. We admit them for 10 to 12 days. We do DYPD before that, multiple electrolytes and CBC checks to happen. So it becomes quite costly also with respect to that.
So Vijay, can I ask a question?
Yes, sir.
So instead of that complicated 5FU regime, 48-hour infusion, can you switch that with capecitabine? At least maybe you will have the toxicity,
So,
but
sir,
the logistics issues may not be there.
So this thought actually came back to us in 2013 when we were planning the study. Can we switch that to capecitabine? Actually, we looked at the phase 1 which was done in head and neck cancer for docetaxel platinum with capecitabine. Actually, that phase 1 had to be stopped because of diarrhea of capecitabine docetaxel led to 3 deaths among 8 patients. So because those results were available, we didn't have the courage to take that regimen forward. So what we did, and this was actually what you say happened with necessity. In the COVID time, in Tata, all our beds went for COVID patients. And so we were stuck, and what used to happen was paclitaxel carboplatin dates at that time in general daycare also, weekly we started giving, used to be delayed. So what we started was, we started giving them metronomic chemotherapy and then started giving them paclitaxel. In 1 or 2 patients, actually our residents forgot to stop the metronomic chemotherapy when the paclitaxel carboplatin started, and that time we saw that they responded beautifully. So then systematically over the next 14 patients, we actually did this study to see whether we gave this regimen of paclitaxel carboplatin and metronomic together, how was the tolerance, how was the effect of that. And to our surprise, it actually get much better responses what we see in with DCF. And you could see the clinical pictures and the clearance which is seen in CT scan actually give some quite promising PFS and overall survival to us. And that encouraged us to actually increase our database, and we actually increased this to 72 patients, and this was presented as a poster in this ASCO, and again this has got submitted for publication. And that is the way the regimen is given. We call it, like Dr. Banawali used to tell us, that if you think head and neck cancer has to make curable, you need to have a regimen like ALL. And we when this was done, we told him, okay, we have something like which looks like an induction protocol where you give weekly paclicarbo interface with metronomic going in between. And we could actually recapitulate our, initially we thought that 14 patient COVID, we were looking at them quite aggressively, and it may be just come by chance, but in 72 patients in a regular OPD also, those things got replicated. In fact, we have another Tata Memorial Hospital Center in Muzaffarpur in Bihar, where people cannot afford even docetaxel cisplatin, and this regimen goes there as a standard, and they have done around 150 patients with this regimen with similar kinds of response rates. So we come to.
So here the metronomic is like the standard TMH metronomic, right?
Standard TMH metronomic, sir. So erlotinib goes as 100, methotrexate goes as 9 milligram per meter square weekly, and celecoxib 200 mg BD with paclitaxel 80 and AUC 1.5 carboplatin going weekly. So let me come to again the surgery colleagues. When we talk about larynx preservation and there are 12 minutes left, we are going for hypopharyngeal larynx. What do we mean by larynx preservation? And let's start from the sides. Okay, yeah. Okay, okay. Voice. Anything else we want to add with that?
Avoid the total laryngitis.
Okay, avoidance of total laryngitis. Sort of anything else you want to add?
Voice preservation and aspiration.
Yeah, yes. No aspirations. Okay, so the unfortunate is the initial definition of larynx preservation, which was used in RTOG and URT study, was actually what was told that avoidance of laryngectomy was considered as voice preservation, and that's the definition what I put for you. And I'll show you why that definition has led to different kind of interpretation among experts. The current definition of larynx preservation is actually quite robust. It takes into account depth, local failure, patient had salvage laryngectomy, a tracheostomy, or even if the patient has a feeding tube which lasts for 2 years or more, that is considered as the larynx is not preserved. And the reason is that not only phonation but swallowing and prevention of aspiration, all are functions of larynx. And we know from the RTOG data that 30% of the unknown deaths which were seen were actually because of and again I'll ask this question to my surgical colleagues, because this will be the counseling which they will be doing. How many patients are willing to sacrifice their life for preservation of larynx?
Many.
I completely agree with that, and this is just to put that in terms of factual data, that only 12.9% of the patients are not willing to sacrifice their life for preservation of larynx. A lot majority are actually willing to say that we are ready for an inferior treatment, but we want our larynx to be preserved. And now I come to again my medical oncology colleagues. So who, if according to, is the best candidate for larynx preservation? If it's a CA larynx or a CA hypopharynx, which would be the patient criteria and the tumor criteria that you would be happy, this patient I will take for larynx preservation?
So I think if there is a superficial cartilage erosion where the patient is technically T4, but you can convert that patient if the patient is responding very well, and you can get the healing and exploration. I think on that patient we can give a neoadjuvant treatment and convert to the non-surgical candidate.
Okay. So what basically was highlighted is if the patient has a T3 disease, that's a minor cartilage erosion. Obviously, you need to do a swallowing function in this patient to look for whether the larynx is functional or not. Both these factors need to be taken into account. I come to my surgical colleagues. Do you want to know whether this patient would be a good follow-up candidate if you want to do larynx preservation? And why would be that?
Obviously doing in the future,
Yes.
because all cancer is all about the follow-ups.
Yeah.
Even we are just telling about the 6 months, 10 months, 2 year, 5 year survival rate.
So that's a good point which is brought up. Whenever we look at the results of larynx preservation, we look at the PFS and the OS, especially the OS, but more of the time they look similar. We need to understand that 47% of these patients in all the studies have actually undergone salvage laryngectomy. So not only that the patient's disease should be good, he should be a good follow-up candidate also, because if he's not a good follow-up candidate, the results are not going to be. And I'll show you some real-world data what happens if the patient is not a good follow-up candidate. So this question I'll take it by medical oncology. If you do larynx preservation in hypopharynx, at the end of 10 years, how many larynx actually you preserve?
Sorry, I didn't.
So the question is, today in 100 patients I offer larynx preservation, and it may be CT-RT, you are not talking about that, it may be NACT followed by RT. At the end of 10 years, in how many patients the larynx are going to be preserved?
20-30% if it is locally advanced.
Okay.
It depends on the primary stage.
Okay.
If the patient is a T3 patient, I think 9% is 70-80%. But if the patient is locally advanced, as you rightly mentioned, 20-30%.
Okay, so we'll look at the results of what happens in hypopharynx in T3 tumors, and we go back to this only study which was done in primary PFS by URTC, in which one arm they operated. The second arm, and we need to understand this, is neoadjuvant chemotherapy, and only if CR is there, the patient goes for larynx preservation. If there was no CR, actually the larynx was knocked off. These were the initial results of the study, and the study always said that both did equally well. Actually, the study actually does show that neoadjuvant chemotherapy did actually slightly better in terms of median, and that P was 0.006, but they looked at the long-term results, and because the curves merged, they did well. And this was the larynx preservation rate in those patients who had functional larynx. At 3 years, it was 42%. At 5 years, it was 35%. And unfortunately, at 10 years, this boils down to only, this boils down to only 8.7%. So we need to be very critical when we are offering larynx preservation in hypopharynx. Now, in this study, you selected the best of the best patients. Those who had a CR only went under it, and in spite of that, so we need to be very critical when we are giving larynx preservation, especially in hypopharynx. And I'll come to the why Dr. Kaushal said that 10 years you could get results, and those are basically when you look at sites like larynx. And when you look at larynx, and I'll come to the RTOG data here. You had radical radiation, radical chemoradiation, induction followed by radiation. And this is what were the initial results. The initial results suggested that the larynx preservation rate is upwards of 80% with CTRT. It was lowest with RT, and was somewhere between with the induction chemotherapy. Now, the problem is the definition with RTOG used was this one, the up one, that is absent of laryngectomy. So if any patient had a failure and refused laryngectomy, he was censored. If any patient died before laryngectomy, he was censored. And what it does was, at 10 years, you could see that the laryngeal preservation rates is 80%, but you could see the survival has dropped down to 20 to 30% because those patients who died with an intact larynx actually got censored. And if you looked at the 10-year outcomes, and let me read out the 10 years outcomes for you, 10-year overall survival. It was 40% with induction followed by RT. For CTRT, it was 28%, and for RT alone, it was 31.5%. And this is where the follow-ups come into picture, and that's why I said, because 30% of these patients had unknown deaths and they died because of it. So it's important that we have a proper definition of larynx, we have a proper follow-up in this case, and you may choose whichever way you want to give, neoadjuvant followed by RT or CTRT, but the selection criteria for these patients need to be important, and it's important that we follow up these patients well. This is very well depicted in this diagram, where you could see that a lot more amount of patients actually died in CTRT because of complications. And 4 minutes are left, last few T4 larynx hypopharynx. You said surgery, surgery, surgery. Patient says, no, I don't want surgery. I still want to preserve my larynx, and I'm okay if the lifespan goes up. So in a T4, which would be the candidate who would do best for larynx preservation? Yeah, that's one, who responds to NACT. Okay. So I'll just show you this data. This data came from Tata, and this was published by my dear friend Dr. Shiva. He divided this T4 into 3 types. The first type of T4 is one who does not have cartilage erosion but has extrathyroidal extensions. Second is the one who has cartilage erosion. The third is the one who has both. And if we look at this outcomes, the patient who did well was who had extralaryngeal spread without cartilage erosion. This was the patient who actually did well. We need to understand that these patients can be a candidate, but this is a risky business, and if you could see, even in hypopharynx it would be labeled as category 3. Surgery is the treatment. In larynx also, in few patients who decline surgery, only this option stands. So we need to be very careful about choosing these patients, because the outcomes of T4 who don't undergo surgery are, in this study also, there was a statistical difference which was seen if T4 underwent organ preservation protocol as opposed to a T4 undergoing surgery. So surgery remains the cornerstone in a patient of T4A. If the patient is very motivated, then we can try this, and this is what I was trying to show you, that when you look at the curves, there is a difference in both PFS and overall survival. In T4 patients, actually surgery does much better than A. In fact, if you break the curves for T3 patients also, you could see that even in T3 patients, actually surgery does much better than organ patient, though it has become a habit to send patients of T3 to him. This is my last 2 minutes are left. Last thoughts. Neoadjuvant immunotherapy. Has anyone used it, and what are your thoughts on that? Dr. Kaushal.
As of now, we have not started, but I know there is a lot of phase 2 data which is very much positive, especially with the combination of nab-paclitaxel with carboplatin and with avoiding the steroids. And I think there is a data of Dr. Ajaris of nivolumab, and also here the upcoming data of keynote study of pembrolizumab in this time. It's going on, but currently we are not.
It's going on. That's correct. I just wanted to show this. So this was the data presented by Dr. Ravi Uppalari. Single dose of pembrolizumab was the first cohort. Second cohort is 2 doses of pembrolizumab. And if you could look at the major pathological responses, with a single dose itself, the major pathological response was 22%. With 2 doses of pembrolizumab, it was close to 43%. And what it actually did show was this well intermediate risk, high risk patients. And you could see that only one step has gone down, and these patients had nearly good survival for 30 months in this situation. So maybe in future, we might not be discussing anything about DCF or anything. We might be discussing something what this keynote study is doing, which is going 2 doses of pembrolizumab before doing the definitive local treatment. Similar data actually is there for nivolumab, and a study is going on. 1 minute is left. If there are any questions, anything I'll take, or we can find it up.
So you think there is a role of low dose immunotherapy in neoadjuvant setting also?
Sir, I actually thought that in 2016 I had written a full protocol of 500 patients. In 2016 itself of giving low dose immunotherapy as a neoadjuvant therapy. Unfortunately, my IC didn't agree with me, and it stopped the project. Now actually they have asked me to revive the project back, saying that, but the way the data is going, and he pointed out that correctly, there are at least 7 to 8 phase 2s which show that single agent pembro, single agent nivo having major pathological responses. And the good thing is that up till now, whatever data used to come from North America, it used to be heavily dominated by HPV positive oropharyngeal cancers of 70%. Surprisingly, the data of neoadjuvant which is coming, it is dominated by oral cancers. So that data I think would be applicable to us much more than the applicability of tax 323 or 224, which data were heavily dominated by oropharyngeal patients.
Yeah, just a comment from your side.
Yeah.
Any data of replacement of 5/5 cetuximab or single methotrexate?
So
so TP plus cetuximab or TP plus methotrexate, which is weekly. Any thought on that?
So we have not tried that. If we have to replace, we now after that paclitaxel we do that, or we have actually given in few patients we have given immunotherapy along with.
Because some patient with underlying cardiac EF is common.
Yeah.
I think usually I replace the 5/5 with cetuximab patient affordable or methotrexate.
It should respond because TPAX has a similar response rate. Yeah, and should have less side effect also.
I do in my practice.
So I think you and TMH has some data with the other anti-EGFR monoclonal antibody, nimotuzumab.
So our data of nimotuzumab is restricted in CTRT setting and palliative setting. We had we had actually asked the company to help us. We had actually planned a study and to sponsor the study with nimotuzumab. They didn't do that, sir. So we have very limited experience with using nimotuzumab in locally advanced setting. We have experience of using it in obviously with as a concurrent along with cisplatin, and we used to use a regimen called gemcitabine nimotuzumab, which used to be given after cetuximab failure. It had some benefit, but it was not that convincing enough. In fact, triple metronomics started doing so well that we stopped using that regimen.
But the Biocon is promoting their agent basically based on the TNS data.
So our data is only in CTRT setting. We don't have a data in other settings. Yeah.
So younger age group patients which we operate in head and neck, even after good surgery, good margins, they tend to recur more. So if there is something which needed to be done after this radiation, if they require.
So I am glad that you brought it up. In fact, normally I make a point to show a slide for that. We had 3 to 4 studies in which one first study was patients who undergo salvage surgery, and the salvage surgery is done, and there is some high risk feature. Patient is not fit for irradiation. We did a randomized study of observation versus giving metronomic chemotherapy. It was what I call as double negative. The patients in the metronomic arm did poorly than the observation arm. That study actually triggered us to do a unplanned interim analysis of another study, which was what you were suggesting, that patient has completed CTRT, is in a CR. We had randomized to observation or metronomic. We did that unplanned interim analysis, and to our surprise, it had similar results. Metronomic was found to be harmful. That triggered us to do an interim analysis of another study in esophagus squamous cell carcinoma, in which similar thing was missed, and in that also there was harmful effect of metronomic chemotherapy. So at present we are very clear there are 3 studies which have shown that in such patient probably doing observation is better than doing metronomic chemotherapy.
I think the similar thing is happened in the patient who recur within a year of radiation.
Yes. Yeah.
And there's no need of there's no data of that giving adjuvant radiation.
Yes.
Patient recur, and
Yeah.
lot of patient is put on the metronomic.
Yes.
There is no data
Yes. That was the first study which I showed that there is actually is harmful to the patient. So no, at present we at present are planning a study, and we are waiting for funding for that study. In this setting, we are trying to see if immunotherapy can work, but we are waiting funding for that. Thank you. Thanks all.